Before I dive in, I just want to be clear that I am here today as a patient. All perspectives are my own and are not reflective of the work I do at NCATS at NIH. So before I actually even start the full presentation, I'm going to start with a little story about my childhood so you can get to know me. My mom didn't let me watch Disney princess movies growing up, and I didn't understand why. I finally saw The Little Mermaid for the very first time, I want to say 5 or 6 years old. And when I asked my mom what the big deal was, she said, well, Ariel gave up her home and her family and her friends and her voice for a man that she met for all of 30 seconds. And I, at the time, didn't understand what she was trying to get at. And I said, but Mom, she could just learn sign language. What's the big deal? But now, as an adult, I very much understand what she was trying to teach me. And she taught me to be the hero of my own story, not to wait around for anyone else to save me, and to never allow my voice to be stolen from me, even by my own body. And that really defines my story going forward. So we don't have time to go through my entire rare disease journey, so here's kind of the highlights. I describe my body as an oxymoron. I have a rare platelet disorder. That means my platelets aren't sticky enough, so they shouldn't be able to clot. But I have a rare neurovascular disease that, in addition to a variety of neurological symptoms, also causes me to get blood clots all of the time. Made treatment really difficult. So I've had multiple serious neurological events, transient ischemic attacks, seizures, and actually the night before the Common App, which in America is how you apply for college, the night before that launched, I had a full-blown stroke. I spent a year relearning how to read, write, and speak. I've relearned how to walk 5 times, and I am wearing heels today, actually, which is a very big deal for me, but I did bring sneakers in my backpack, too. I was on chemotherapy for 3 years. It was repurposed. I was on cancer patient doses, and that is what eventually put me in remission. But about 2 years ago, I actually relapsed and went back on one of the chemotherapy drugs for a year, and I'm back in remission now. And so that's kind of what my life looks like going forward, most likely, but it's still a life. I am still, at least I have options. I know what to do in these cases, and that's still really exciting. This is a picture of me from my college graduation. If you can read the cap, it says, long story short, I survived, and that pretty much sums up my college experience. So I actually took a pretty roundabout way to getting to where I am today. I thought I was going to go into political communications. When I found out I was sick, taking a page from my mom's Disney princess lessons, I went into policy advocacy. I worked on 21st Century Cures and Open Act. I actually worked very closely with Every Life Foundation and helped to co-found their young adult legislative advocacy group. And that's what I wanted to do. I also had been told that I would never be able to have a career in STEM. I was told that I couldn't do science or math. In undergrad, I actually took 2 different statistics courses, had to medically withdraw from them because I was failing them before they gave me an accommodation to say, your neuropsych testing says you cannot do this. Now I am a master's student in clinical and translational research with a concentration in biomedical and mechanistic studies. Say that 5 times fast, it's a mouthful. And I took biostats in my first semester and got an A. And you might be wondering why I'm telling you this and kind of rattling off a resume here, and it's twofold. Number one, this is a prime example of the success of drug repurposing. I wouldn't be here talking to you today without drug repurposing. I wouldn't be doing the work that I'm doing. I was told by my neurologists, neuropsychiatrists, hematologists that I would be getting early onset dementia. My brain would be basically mush by the age of 25. And I turned 25 at the end of this month. And I'm planning on applying for PhD programs in the biomedical sciences, very interested in bioinformatics in the fall. And I graduate this summer. It's a really, really big deal. And the second is because I was really insecure in the beginning about my political communication background. When I wanted to transition to research, I thought that this was a hindrance. And then I realized that it's actually the best asset because we can look at this from multiple different angles. So this is Iris Long. When I was applying to my undergrad political communications program, I was asked to write about a political figure that I admire. And I chose a chemist, Iris Long, who during the 1980s HIV/AIDS crisis actually went and taught patients and their families what AIDS was, how the mechanism of the disease worked, what types of drugs, which were actually repurposed drugs at that time, could work to target it, how to talk to the NIH about clinical trials, how to talk to the FDA, what mattered to them most. And maybe I should have realized in hindsight the path that I was going to take by the fact that that's who I chose as my political icon, but I didn't. We're here now. So I think that this approach is really critical for rare diseases as well, to look at this from a holistic lens and to make sure that patients are as educated as possible on the actual science behind it. So what do we need to do? Educate patients and care partners, create unity within the rare disease community, increase diverse stakeholder engagement, harness the power of technology, and keep accessibility at the forefront. How do we do that? So, for education, the onus is not only on patients to do their research. Rare disease moms are often referred to as binder moms. They come in, they've done all the research, we know what's best, but we shouldn't have to do that. Our doctors should be helping to teach us these things. I was very lucky that my mom put me in positions where when doctors would ask her, oh, how is she feeling? She would say, well, she can answer for herself. Why don't you ask her? I was lucky that I had a doctor that actually took the time to teach me why we were trying all of these drugs, especially because they were all repurposed, so that I could understand. I didn't have to go back and try and research all of this on my own. And I think that's a really critical piece. There are organizations, Global Genes has a program where they match med students up with a rare disease family so that that med student can learn about rare disease and build more empathy in what that's like. I propose almost a reverse program where we have med students partnered up with these families to then teach them the science behind their disease, the science behind the mechanism of action, how to go into these appointments and understand what your doctor is talking about. And I think that that could be very helpful in terms of repurposing and also just patient engagement in general. As far as stakeholder engagement, this meeting is huge. We have so much representation here, and that's amazing, but we need to do this more frequently. I know Heather talked earlier about Cure ID and the CDRC, so that's an opportunity to get involved there. I'm working on a project right now, interviewing different stakeholders on the barriers from the preclinical to clinical translational pathway of drug repurposing. We have a poster later. If you are interested in being interviewed, it's an ongoing project. Please let me know. And then from a technology standpoint, I really believe that precision medicine is the future for rare disease patients. And I think that there's so many cool things happening with AI and in silico modeling and clinical trials through that or using that as supplemental data. I don't have a ton of time, so I'm not going to spend too much on that. But if you want to talk about that and be a nerd with me after, please come find me. And then from accessibility, which I think is the most important piece. If you have a drug and you have a signal and you know it works, it means nothing if you can't get it to a patient. It means nothing if payers aren't willing to pay for it. It means nothing if doctors aren't willing to prescribe it. So we have to think about access from all of those different lenses. And this is my last slide, but I think it's the most important slide of all. I'm not the norm. As you can tell, my parents and I are very close by this entire presentation. My mom always said that normal is just a setting on the dryer, and so take that as what you will. I don't know what normal even is, but I know that I'm not it. I am extremely privileged. Most patients with my prognosis, with my background, wouldn't be standing here today, and not just because of the drugs, but because of the actual access I had to treatment. My mom was a social worker. She worked in many different fields, but one of those was oncology. She knew how to navigate a health system, and she knew how to get access and had connections within our local hospital. My dad was a lawyer. He was able to access and understand insurance and all the different claims. Most people don't have that. My aunt was an ER nurse. That also gave me access to hospital connections, and it meant that sometimes she was able to give me treatments at home. She would come give me antibiotic injections because I couldn't do IVs because of my vascular disease, kept me out of the hospital. My uncle was a podiatrist, not the most relevant to my disease specifically, but again, connections. My grandfather was one of the founding doctors at St. Jude Children's Research Hospital, one of the most advanced hospitals for pediatric rare diseases and cancers. I had so much going for me that so many people don't have. I'm a woman, which means I have definitely faced sexism in medicine. It's just a fact, especially in being told that it's all in our heads, which I guess technically the doctors weren't wrong considering I had blood clots in my brain. But I think they meant that I was making myself sick, which I wasn't doing. So, you know. But I'm a white woman, which means that I have not faced nearly as much discrimination or challenges as my BIPOC counterparts have. I'm straight-sized, which means I fit into any clothing off the rack. I haven't had doctors tell me, oh, all of your problems come from weight. You need to lose weight. That's why you have blood clots. That's why you have high blood pressure. So my story is not the norm, and we need to talk about that when we're talking about drug repurposing and when we're talking about access. Inequality and inequity, which are different, are the basis of repurposing. And so sometimes I think I'm kind of the unluckiest person in the world, especially when you hear my story and it's just like, wow, how could any of all of these things happen to one person? But I might actually be the luckiest because I was born into the family that I was. I had the opportunities and the privileges that I did. My parents were able to travel for medical care. I've been to over 10 states in the United States seeking the best doctors. I was able to pay out of pocket for certain treatments if needed while we trialed them, and then were able to get insurance to cover it after. I had incredible healthcare insurance. All of these things set me up for success in ways that others weren't. And so for every patient like me, there's a patient like Amelia. Amelia was my roommate in the hospital, and she was discharged far too early because her insurance stopped paying for it, and shortly after, she was brought back in through the emergency room all over again. Amelia's parents were not the most educated in healthcare communities, did not know how to navigate the space. She did not have as good of insurance, which not only led to them not covering things like important hospital stays, but meant that drug repurposing wasn't really a huge option for her. Traveling for care was even harder. Amelia passed away in 2016 at the age of 24, which is exactly how old I am now. And something that a lot of us rare disease patients, and I'm sure rare disease families too, deal with is survivor's guilt. And I want to live in a world where survivor's guilt is non-existent. I want to live in a world where survival isn't luck-based, isn't who you're born into, where it's just something that is accessible to everybody. And so I think for people like Amelia, it's important for me to be able to advocate for them when I am in these luck-based situations. Thank you very much.